process. Now, the functional goal of oral cavity reconstruction, which are intelligible speech, which is understandable, then isolation of oral cavity from sinuses and nasal cavity, then unrestricted mouth opening, stable occlusion and mastication, swallowing, all related to feeding, then avoid aspiration, then coverage of neck and maintenance of an intact intraoral seal to prevent life-threatening complications such as blowout of great vessels of the neck due to leakage of the saliva. Now the workup of patient undergoing reconstruction. Routine workup like blood, all kind of blood tests, ECGs and chest X-rays and all. Then we show this patient to the anesthetist for pre-anesthesia checkup. Now we use the term prehabilitation. That means we not only show these patients to anesthetists, but to dietitians and physiotherapists also. Then the preoperative assessment and planning after discussion with oncosurgeons. An accurate preoperative prediction of size, depth, location, and extent of ablation is required. Then photography for the records and consent. We explain the pros and cons of all kind of flaps and whatever options are available for that particular defect. Then we do Doppler, CT angiography, MRI angio to assess the vascular anatomy and location of perforator if required, not in all cases. Nowadays, we also plan the mandibular osteotomies with the help of prefabricated mandible templates and jigs, which are made, which are based on CAD/CAM, which is computer-assisted design and manufacturing. These are the pictures, computerized pictures of this fibula and reconstructed mandible. And here, these are the models prepared and jigs for osteotomy of the patient, or osteotomy of the fibula for mandibular reconstruction. Now the selection criteria of reconstructive options. For primary reconstruction of ablative defect, the optimal reconstructive option need to be decided before operation. It should be based on the prognosis. If prognosis is poor, we choose simpler options. Then general medical condition of the patient. Suppose if ejection fraction of the patient is less than 40%, in that case, we do not prefer the free flaps. We do simpler procedures, any regional flaps, etc. Then the condition of donor site. If donor site is injured, if there is history of previous fracture, any skin lesion over there, then we change the site, either change the site or change the option. Then the occupation of patient. He wants to avoid any scar on the exposed part. So we avoid the radial artery foramen flap, which is visible. Then we avoid taking nasolabial flap because all leads to visible scarring. We choose different flap instead of these two. Then the history of previous surgery or head and neck radiation. If that part from where we are planning to harvest the flap is irradiated, then we do not prefer that flap. Instead of that, we prefer distant flap or free flaps or regional, not actually the regional and local flap. Then the selection of flap also depends on component of ablated tissue. If bone is excised, then we get the bone. If soft tissue is removed, then we replace it with a soft tissue. Then a surgeon should consider the facility available and his own experience, comfort, skill, and knowledge of local, regional, and distant anatomy. Now, few words on resection. And resection of cancer should dictate reconstruction, not vice versa. Oncosurgeon should not restrict the excision as per the reconstruction method he knows. Rather, excision and reconstruction should be done by separate team. Excision by the oncosurgeon and reconstruction is left for the plastic surgery team. Now the reconstructive options, it ranges from direct closure to closure by secondary intention, skin grafting, local flap, regional flap, distant flap, and free tissue transfer or free flap. One by one, direct closure where ample soft tissue can be mobilized to achieve closure without compromising oral function. For example, tethering of tongue, trismus due to shortening of mucosa. Then closure by secondary intention. Wound is allowed to granulate if it lies, for example, tongue and floor of mouth. And defect can be closed partially and rest is left for healing by secondary intention. Wound heals with contracture and scarring. So it must not jeopardize function by impairing motility of tongue. Then skin graft. It's good for small defects which cannot be closed directly. For example, anterior buccal mucosa defect without involving any bone. That can be used after partial maxillectomy where maxillary prosthesis is planned. Local flap within the oral cavity. Small defects where bone gets exposed after the ablation. Then local flap provide thin sensate cover for light tissue for small defects, and it may not be a viable option where area adjacent to the defect is included in the radiation field in previously irradiated patients. Examples are tongue flap. Tongue flap is a versatile flap to cover small intraoral defects, but care must be taken not to compromise tongue function. Fan flap, this facial artery musculomucosal flap. It's a reliable axial pedicle flap to cover moderate intraoral defects, but its use must not compromise normal oral function and mobility. Next is palatal flap, another example of local flap. It can be used as transposition flap for a small palatal defect on other half of the palate, and it can be islanded based on greater palatine artery for buccal mucosa defect. Regional flaps. These flaps are from other part of the face like nasolabial, forehead flap, submental flap, and temporalis muscle flap. Uh, Nasolabial flap is used for buccal mucosa, tongue, lip, and palate. Here it is harvested from nasolabial fold, transferred inside the oral cavity. Insert is done, and this is the closed donor site. Forehead flap. This is used for palatal and buccal mucosa defect. Donor site is a split skin grafted, but it looks ugly. That's why we rarely use this flap, and it should be used when no other option is left. Submental flap. Because of the bare area in males, this flap is not used for the reconstruction of the floor. It is used particularly in females for the floor reconstruction. But there may also be a concern about using a flap from lymphatic drainage territory of the tumor site. Distant flap. These flaps are from distant site, such as chest, like a deltopectoral flap and pectoralis major myocutaneous flap. Then sternocleidomastoid muscle is raised in the neck area, which is less reliable due to its vascularity. Then from shoulder, we can raise supraclavicular artery island flap, and from the back, we can harvest trapezius musculocutaneous flap. Now, one by one, this pectoralis major muscle or myocutaneous flap is a workhorse flap, and every surgeon, reconstructive surgeon and oncosurgeon must know how to do it. Based on thoracodorsal branch of thoracoacromial trunk, pectoralis major flap can be used as only muscle flap for the coverage of the large vessel of the neck after neck dissection and for the coverage of primary closure of pharynx after total laryngectomy in post-radiation patient. It also used as myocutaneous flap with single or double skin paddle for the reconstruction of oral as well as through and through orocutaneous defects. Uh, a skin paddle over the muscle is supplied by perforators of branches of thoracodorsal artery. Inclusion of sixth rib with the flap can also be used to bridge the bony defect of the mandible, although it is not a good choice for a bony reconstruction. Main advantage of this flap is that it is easy to harvest and can be used as good option for reconstruction of composite defect of oral cavity in those centers where microvascular reconstructive facilities are not available. Here, this is a design of the pectoralis major musculocutaneous flap. Uh, Here in this pic, this uh, flap is harvested, dissected, and you can see the reach of this flap. This is up to maxilla. This can be used for maxillary defects. Deltopectoral flap. This is one of the pedicle fasciocutaneous flap based on the anterior intercostal perforators of internal mammary artery. Disadvantages of this flap are it may need delaying procedure to enhance its length, and also requires one more stage to divide its pedicle to complete the inset of flap, and one side need to be split skin grafted. Then supraclavicular flap. This flap is a fasciocutaneous flap based on supraclavicular artery, a branch of transverse cervical artery. It is a thin, pliable, versatile, reliable, and easy to harvest with good cosmetic and functional outcome of both recipient and donor side. This is the reconstruction of complex head and neck oncology defect can be reconstructed in single stage with this flap, and it is an excellent alternative to traditional regional and free flaps. Now, the reconstructive paradigm. In the past, according to the concept of reconstructive ladder, free flaps were considered as a secondary option where skin graft or local flap had failed to achieve acceptable results. But now the concept of the reconstructive elevator or reconstructive pie has been widely accepted, and reconstructive microsurgery is becoming one of the first preferences with excellent functional and aesthetic outcome. Now, the free tissue transfer. It's an island flap based flap detached from one part of the body, which is with its feeding vessels or pedicle, and reattached at the distant recipient site by microvascular anastomosis. Nowadays, it is a gold standard for the reconstruction of the soft tissue and bony defect of the head and neck. Advantages of free flap includes single stage procedure, its faster recovery is there, effective in poorly vascularized site, for example, post radiotherapy. Then success rate is predictable, then axial flap, donor site selected to minimize morbidity. The wide range of donor site is available. More appropriate flap with replacement of lost tissue with similar components. Allow the option of incorporating any tissue type like skin, muscle, tendon, or bone. It can be tailored to the specific defect, and lost function can be restored. Disadvantages are it requires microvascular equipments and expertise, uh, trained staff, surgeons, and nurses. Uh, Duration is very long. Failure is usually total, and technique relies on suitable vessels at the recipient site. Now, steps of free tissue transfer. After the excision, the defect is measured. Vessels at neck are prepared for anastomosis. Flap is marked and dissected from the donor side. Feeding vessel or pedicle flap is identified and dissected. Flap pedicle is divided and the flap is transferred to the recipient side. First, we do the partial inset of flap. Then flap vessels are anastomosed with the recipient vessel at the neck. Then inset of the flap is completed and closure of the neck wound is done over the drain. Now, the method of anastomosis of vessels. All the arterial anastomosis are done with the help of sutures, but in venous anastomosis, we can do with either with the sutures or with the venous couplers. Now we are using this venous coupler for the anastomosis because chances of thrombosis are less in this technique. Now the post-op monitoring of free flaps. Uh, Help of experienced nursing staff is needed in surgical ICU for proper and regular monitoring of flap. Many sophisticated techniques like ultrasound, implantable ultrasound probes, monitoring with the indocyanine green dye are available, but most reliable is clinical monitoring. If flap is pale and wrinkled, that means arterial insufficiency is there. If congested, blue and swollen, they may be the obstruction of venous return. Then, with the help of scratching with a needle or pricking the flower with a needle, uh, we can see the normal bright red bleed. If that's there, that means flower is fine. If there is no bleed, then arterial insufficiency is there. And if dark bleed, then venous return is hampered. In this first picture, you can see the bright red blood on prick. That means that this flap is healthy. And in this picture, you can see the dark blood on prick. So in that case, before exploration, we look for the tight dressing, strangulating sutures. If there, we remove it. Then hypothermia or hypertension is corrected. And if no improvement in half an hour, we re-explore the wound. We may find hematoma compressing the pedicle. We evacuate the hematoma. If we find kinking, we fix a pedicle, realign it. If twisting of pedicle is there, we open the anastomosis and then re-anastomosis after untwisting of the pedicle. If we find venous thrombosis or arterial thrombosis, we open the anastomosis, remove the thrombus, and re-anastomosis. Delay in re-explosion may lead to loss of flap and require second flap. Now, examples of free flaps. Most common flaps are radial artery forearm flap, anterolateral thigh flap, free fibular osteocutaneous flap, and most of the oral defect can be reconstructed with these three flaps. Other free flap commonly used in oral reconstruction are medial sural artery perforator flap from calf, profunda artery perforator from medial thigh, superficial circumflex iliac from the groin, then thoracodorsal artery perforator flap from lateral chest, lateral arm flap, or scapular flaps. Free radial artery forearm flap was first described by Young in 1981 in China. It's also known as Chinese flap. As the name suggests, it is based on radial artery of forearm. Indications are buccal mucosa, lip reconstruction, tongue reconstruction, and parapharyngeal reconstruction, soft palate. In this picture, after glossectomy, partial glossectomy, it is reconstructed with the radial artery forearm flap. Here, tube of neopharynx is prepared with the radial artery forearm flap. And in this pic, lower lip is prepared with reconstructed with the radial artery forearm flap. Advantages are this thin pliable skin, reconstruction of contour, sulci, vestibule is easy, highly tolerant to radiation therapy. Composite flap can be raised with bone, tendon, brachioradialis muscle, and vascularized nerve. Sensory recovery reported in patient even when a neural anastomosis is not performed. Skin from entire forearm can be harvested. Disadvantages are unsightly appearance of donor side due to split skin graft. There is racket type of scar, loss of sensation over the dorsum of hand due to injury to sensory branch of radial nerve while raising the flap. Then tendon at distal forearm may get exposed. Next is free anterior lateral thigh flap, which is workhorse flap, can be used in any kind of defects. It was first reported by Song et al. Vascular pedicle is formed by descending branch of the lateral circumflex femoral artery. Indications are buccal mucosa defect, through and through oral defect, upper and lower lip reconstruction, reconstruction of neopharynx, tongue, or partial or total, then palatal reconstruction with partial maxillectomy, and to fill cavity after total maxillectomy. In high risk patient, for mandible reconstruction, instead of free fibula, we use ALT with reconstruction plate to save time. Another type of ALT. This flap can be raised as faciocutaneous flap with skin and fascia only, musculocutaneous flap with muscle and skin, facial flap, only fascia is harvested, adipofacial flap with the fat and fascia, and as chimeric flap. If there are more than two perforators, we can harvest flap with the skin paddle and the muscle. Then we can harvest two skin paddle on two different perforators for through and through defects. Then a muscle only flap can be raised, where vastus lateralis is raised on the same pedicle. Then it can be used as flow through flap. Advantages are almost all the defect of head and neck can be reconstructed with this flap. Large skin paddle can be harvested. Long skin paddle on multiple perforators can be harvested. Pliability is good. No major artery is sacrificed. We can harvest muscle with the skin to obliterate cavities and for contouring. If we can close the donor area directly, donor side morbidity is minimal and it can be thinned. Disadvantages are rarely perforated are not found. In that case, we can harvest anteromedial thigh flap or tensor facial lata flap through the same incision. And sometimes difficult to dissect when perforator is traversing through the muscle. Next is free fibula osseous and osteocutaneous flap. Taylor first described vascularized free fibula in 1975. Hidalgo used it for mandibular reconstruction in 1989. Vascular pedicle consists of peroneal artery and its vena comitatus. And indications are mandibular reconstruction and maxillary reconstruction. Here we can you can see the nice contour after mandibular reconstruction. Here it is used. This fibula flap is used for reconstruction of the maxilla. Advantages are 25 centimeter of bone stock can be harvested, enough for whole mandibular reconstruction, ideal for osseointegrated dental implant placement, can be used as vascularized bone, can be raised as osteocutaneous flap, osteomusculocutaneous flap, and double skin paddle flap. And main advantage of this flap is that it does not require change of position on the operation table. Otherwise, scapula, vascularized scapula flap for reconstruction, we need to change the position of the patient. Disadvantages are in 5 to 10% of cases, blood supply to skin paddle is inadequate. Donor side problems are there, edema, weakness in the dorsiflexion of great toe, sometimes. Skin graft is required to cover the donor site, poor donor site appearance, and rarely we get peroneal magna where only single peroneal artery is present and other vessels are absent. In that case, we have to abandon this procedure. Now, component-wise, this construction of oral defect. Defect of oral cavity can be divided into three groups: only soft tissue defect, soft tissue with bone, and only bone defects. Defect needing soft tissue reconstruction only. Buccal mucosa defects, depending upon the size of defect, it can be closed directly, left for healing with secondary intention or split skin grafted. Moderate size defect with exposed bone can be covered with local flaps like nasolabial or tongue. Larger defect, including marginal mandibulectomy, also in case of excision of lesion of RMT area, are covered with either regional flap, for example, packed major, myocutaneous, or if expertise are available, can be reconstructed with radial artery forearm flap or anterolateral thigh flap. Palatal defects. Soft palate is a dynamic structure and difficult to reconstruct. Thin flaps such as RAF are best suited for this defect. Hard palate. Reconstruction of hard palate is frequently achieved with prosthesis. An obturator attached with dental processes is being used to plug the palatal hole after lining the defect with simple split skin graft. An isolated hard palate defect can be covered with free RAF or ALT flap to separate the nasal cavity from the oral cavity. Tongue, with or without floor of mouth. Tongue is a unique muscular structure within the oral cavity. It plays an important role in articulation of speech, appreciation of taste, and initiation of swallowing. Priorities of reconstruction of tongue includes airway protection, swallowing, and articulation of speech. Functional reconstruction of this dynamic structure is difficult to achieve. The most appropriate reconstructive choice depend on the size of tongue defect. A smaller defect can be closed primarily. This is the classification of glossectomy. Small defects or partial less than one third can be closed primarily, and other need reconstruction with some kind of flap. For partial glossectomy, thin pliable flap as RAF is a flap of choice, but reconstruction should not affect the mobility of the remaining healthy tongue. After hemiglossectomy, free LT is the flap of choice because of its bulk, and near total glossectomy leads to permanent swelling problem. A bulky flap like free LT or rectus abdominis myocutaneous flap helps in swallowing of food in such situation. Now, defect needing both soft tissue and bone. After segmental mandibulectomy with buccal mucosa or floor of mouth, need composite tissue for reconstruction, including both skin paddle and piece of bone. In such situation, flap of choice is free fibular ossicutaneous flap. Main advantage of this flap is that not only it bridges the bony gap, it also provides a good quality bone stock for dental rehabilitation. Uh, we can also reconstruct it with reconstruction plate with pectoralis major myocutaneous flap in high risk patient. But in posterior segmental mandibulectomy, it may not require, which may not require bony reconstruction, and soft tissue defect reconstructed with pectoralis major flap is sufficient. Maxillectomy with or without orbital floor. It requires free fibular osteocutaneous flap for the reconstruction. Sometimes it can be reconstructed with temporalis muscle with a skin graft, but in such cases, dental rehabilitation is not possible. A defect needing bone early. Mandibular excision for ameloblastoma, where mucosa is not at all involved. Simple bony reconstruction with free fibular flap without a skin paddle is enough. Iliac crest and scapula vascularized bone flaps are all other examples of free flap for bony reconstruction. Through and through defect, both lining and cover are needed. In soft tissue defect, we can use this ALT flap for lining and as well as the cover. And if bony defect is also there, then we can put this double paddle free fibula for both reconstruction of bone, lining, as well as the cover. Now, secondary surgeries in reconstruction. For the complications, reconstruction of head and neck defect does not end at the primary surgery. Unfortunately, every surgeon will experience several reconstruction failure. For example, partial or total flap failure, fistula, then disruption of suture line, pooling of secretion and infection in the neck can lead to life-threatening complications such as carotid artery blowout. Early debridement and coverage of exposed vital structures with another local, regional, or free flap are required in such cases, depending upon the extent of defect. Some cases do heal with conservative treatment only. This is a patient came with the disruption of the suture line with exposed plate and exposed fibula. In this case, we did radial artery forearm flap, and you can see the result after some time. Now, secondary surgery to enhance function or aesthetic after reconstruction. Debulking of flap. In this patient, PMMC was done. Debulking of flap to enhance facial contour, symmetry, and aesthetic outcome, and can be performed under local anesthesia. Sometimes we need secondary vestibuloplasty, which allow for delayed osseointegrated implants. Other procedures may include scar revision or resurfacing of unsightly skin grafted donor site using modalities such as tissue expanders. Lastly, secondary surgery for recurrence. As many patients requiring head and neck reconstruction are cancer patients, a significant number may present with a recurrence requiring further reconstruction. Salvage surgery with free flap reconstruction has been reported to have the best outcome in patients with recurrent T1 and T2 tumors. However, limited application in recurrent advanced T3 and T4 cancer has also been reported. As salvage surgery is often the only curative option for recurrent head and neck cancer, a significant proportion of patients presenting for reconstruction will have previously undergone treatment. In this subgroup of patients, the neck is often scarred due to previous surgery and radiation. Recipient vessels for free flap are hard to find and are often encased in scar. Often vessel from the contralateral neck or vein graft may have to be used. Lastly, our take-home messages. Head and neck cancer defects are complex with complicated function and anatomy, and the reconstruction of these defects not only focuses on aesthetic results but also on functional restoration. Surgical decision making is complex and must be individualized for each patient and each clinical problem. Equal weight should be given to potential assessment, surgical planning, intraoperative execution, and postoperative care because a deficiency in any one area may ultimately lead to failure of the reconstruction. There is always a learning curve to improve outcomes, and everyone should follow the basic principle and essential steps. Thank you.
Thank you, Dr. Rajan.
Thank you, sir.
We'll invite questions from the students. Okay, can I start and ask you, how do you choose which type of reconstruction, or uh, how are you going to repair the defect? Say, let us take the example of CA tongue.
So this is all depend upon the size of the defect, and the functional tongue is left there because if it should not be like that that we reconstruct the defect and the movement of the tongue is hampered. So in case of small defects, we can close it primarily, less than one third defects, or in case of partial glossectomy, we can use thin pliable skin to reconstruct it. And for larger defects, we use bulkier flap for speech and swallowing.
I think tip of tongue is most important, where speech is important.
So,
So even if the defect is less than one third, you may have to repair the anterior third tongue. Am I right?
yes, sir. Yeah, excellent. In that case, we try to provide bulk on the anterior, tip of the flap so that it reaches the palate for the speech.
Mobility of tip of tongue should be maintained, basically.
Yeah, this all depend on the rest of the tongue.
Okay.
It should be, it shouldn't hamper the movement of the left, the part which is left, part of the tongue.
And you've not talked about venous couplers. How do they help? What are the venous couplers?
Uh, so these are the rings basically with the pins on it, and uh, we have the sizes with the help of which we choose the size of the coupler as per the size of the vein. Then we through the ring of the coupler, we pull the vessel's end outside. Through the vessel, we take out the margin end of the vein, and we invert the margin over the pin. So, because of this, the chances of uh, adventitial tissue, peri-adventitial tissue, going inside the cavity, inside the lumen of the vessel, is less. So, in that case, that's why the chances of thrombosis are less in when we use venous couplers.
Are there any arterial couplers? Is
No,
it
arterial
technically
couplers,
possible?
yeah, yeah, arterial couplers are not available. But if wall of the artery is thin, we can use this venous coupler for the anastomosis. We put the ring on both sides with the pins, then we bring it together. Those pins get fixed to each other, and the anastomosis is completed. So for arterioles, it's not available, but if the arterial wall is thin, we can use this venous coupler.
Students, any questions? Quite interesting topic and of course highly technical, but all of you are supposed to know this. Another issue was you said that only bony reconstructions. Suppose you are reconstructing only the bone,
So,
then how will you monitor the viability of bone? There's no skin pedal, there's nothing over it.
yes,
Same
sir.
look.
Actually, sometime we harvest the bone with the FHL, flexor hallucis longus muscle. So we keep the part of the that muscle outside the suture line to monitor. And if anything, if color of the muscle changes, we re-explore the neck. If it's healthy, later on we excise that part and close the sutures of neck.
There's no skin pedicle.
No,
There's no skin pedal.
no skin parison, only muscle part. This muscle part get atrophied after some time.
Anything you would like to tell the postgraduates or FNBs? Uh, they may not be doing the free flaps themselves, but the regional flaps and local flaps, uh, how should they decide where to do PMMC, where to do, say, maybe they are sitting in remote area, some DP flap or nasolabial flap.
So during their training, they can learn all these kind of flap. And I must say, at least they know how to do PMMC flap because it's a workhorse flap, and at least a nasolabial flap. These two flaps are easy to harvest, and nasolabial flap is raised on the facial artery, and sometimes facial artery is divided, but it can be used as a, random pattern flap. So most of the defect of the head and neck can be covered with the this uh, PMMC flap. So if they know this flap, they can do the surgery in the remote areas.
There is a question, can you further elaborate on the types of microvascular anastomosis?
Types of microvascular anastomosis. Uh, uh, it can be end-to-end anastomosis where ends of the vessels are anastomosed. It can be end-to-side anastomosis where end of the feeding vessel or pedicle of the flap is anastomosed to the main vessel at the recipient side when uh, the branches of we don't find the branches of external carotid artery, we do end to side anastomosis. And when veins are depleted and only IJV is there, then we do end to side anastomosis of veins. And I'm not sure actually what do, what is the meaning of this
Can you
type.
elaborate on the question? Whosoever has written this, the type of microvascular anastomosis. What do you want to actually know? Is it end to end, end to side, or something different?
Because it can be hand-sewn anastomosis where we use sutures, or it can be sutured with, can be anastomosed with the help of venous couplers. These are also types of microvascular anastomosis.
Okay. How do you choose the vein, which vein to be anastomosed with the donor, the recipient area vein, directly into the external jugular, directly into the internal jugular, posterior facial? How do you decide about the vessels?
Actually, we usually anastomose this pedicle vessel to internal uh, jugular system because because of this movement of chest during respiration, it provides negative suction and negative pressure inside the chest, which sucks the blood from the IJV. So chances of getting it thrombosed is lesser. That's why I choose internal jugular uh, vein for the anastomosis, not the external jugular. Sometimes get caught in the suturing, or sometimes there's pressure on the vessel because of the suturing of neck sutures. Uh, then the size all depends on the size of the pedicle, vein in the pedicle. If the size of same size of vessel is there, tributary is there in the IJV, we do end-to-end anastomosis. If it's not, if all the tributaries are ligated, then we do end-to-side anastomosis, end of the pedicle vein and side of the IJV.
I think probably that answers the question type of microvascular anastomosis.
Maybe. And one more thing, we do arterial anastomosis first, then we see the flow, venous return in the veins, which when concomitant is showing better venous return. Then we anastomose that vein to the recipient vein. We don't do both veins, both I mean both. We do only single venous anastomosis, not the two vein anastomosis.
And maybe last question, if there is through and through large defect of buccal mucosa, say skin is involved, large area, it is a white composite resection, will you prefer a bipedal flap of ALT or two different free flaps?
So it all depends upon the availability of the tissue. If we find multiple perforator at the donor site of ALT, we prefer to do this uh, ALT flap. Single ALT
Okay,
flap is enough. We can divide the flap
bipedal.
based on
This is bipedal you are saying.
bipedal. By there are two skin paddles,
Okay,
different perforator of the same artery. This is called chimeric flap.
okay.
In case defect is too big and it needs segmental mandibulectomy is there, then we reconstruct it with the fibular flap. But because cavities are there and tissue from the leg is not enough, in that case, we prefer to do double flap. Free fibula flap with the skin pedal to reconstruct the lining and mucosa, and another flap for the reconstruction of the cover. And sometimes we need to fill the cavities and we don't get sufficient tissue from the leg area. In that case, we do double free flap.
Any other questions? Students, Namiji, can we call it a day then? Dr.
Yes, sir. If
Navneet
there are no more questions, we can